Top Med Talk.
This piece is part 2 of a 2-part piece. It's presented by Desiree, Chappell and Sol Aronson, and it follows on from a short didactic presentation which Top Med Talk has already released. For more details, check out the show notes.
Professor Angela Bader. She is a professor of anesthesia at Harvard School of Medicine. I believe the director or co-director for the Center for Surgery and Public Health at Brigham and Women's Hospital. Angela, my dear friend, how are you doing?
I love this meeting. And as you know, Desiree, I've been a friend of EdPom and Top Talk for a while. And I just love this. Is such a great meeting for all of us interested in perioperative medicine. So just saying hello to everybody. And I'm so glad to be here.
Thank you so much. Well, Angela, I want to get into a little bit more about what you're doing there at Brigham. So tell us just a little bit more about some of the things that you're doing to move the needle on the perioperative care.
First, I just want to say for the audience, Sol is really such a benchmarking person in this area. No, Sol, I am a big fan of Sol and Tom and Bob. You know, this is a great panel. So just in terms of my own, I mean, I agree with everything Sol said. And actually, I run a research group at the Center for Surgery and Public Health, which is an interdisciplinary group with surgeons, palliative care people, geriatricians, and different other specialists, because as Sol said, you cannot do this kind of work in a one discipline way. So I don't think we're going to succeed without bringing in all these other disciplines. So our particular research focus, I think, is a little complementary to Sol's, is we take all of those variables that he talks about having impact, and we look at the impact on shared decision-making. So our big research focus at this point is saying, okay, if you do identify all these modifiable variables, how does that impact appropriate shared decision-making and informed consent? And that leads to my second area, which is preoperative cognitive function, because we very rarely take into account the impact of cognitive dysfunction and frailty as anesthesiologists, and in most cases, surgeons. And so we're also doing a lot of work, I think, that's complementary in terms of shared decision-making and the impact of cognitive dysfunction on outcomes and costs. So it all is kind of linked together. And the one final thing I just want to say is we focus so much on cancellations and delays. And I think we have to remember that, yes, it's great for the operating room, but it absolutely has nothing to do with outcomes or costs. So I don't even know, maybe some of these cancellations are a good thing. So, but anyway, we're using metrics that may or may not even be relevant to what we really want to achieve in terms of value. And again, I just want to say thanks, Desiree and Monte. I really enjoy being on these panels.
Next panelist today is Professor BobbieJean Sweitzer from Northwestern University in Chicago, Illinois. BobbieJean, it's so good to see you. Thank you so much for joining us.
Thank you, Desiree. I guess I may be the only person in this whole session or this whole meeting that is actually based in Chicago. Nobody told me not to stay in Chicago. I've been in this business for about a couple decades, and I can't tell you how exciting it is to be here and see what has happened in this perioperative space, and to see that particularly that anesthesiologists and surgeons have finally embraced this need for care outside of the operating room, and particularly leading up to the operating room. I started out in internal medicine, and I practiced medicine for a number of years before I went into anesthesiology. And, I did that thinking I wanted to do critical care, but almost from the moment I entered anesthesiology training, I realized that there was this whole, absence of evaluation and optimization and focus on truly what matters for patients having surgery. Because as internists or primary care doctors, it's all about sort of, your 10-year life expectancy or your 20-year preventive care, or treating, chronic conditions in a very different way. And, Angela and I luckily met relatively early on, and her background had been in pediatric training. So I think that also informed our interests and our focus on this need to bring this multidisciplinary approach to this. So I would say that generally over the years, my focus has been a lot on education and development of training programs, both for anesthesiologists and internists and surgeons, frankly, that are going to be practicing, as well as, recognizing early on that as a cost-effective model, I believe we needed to move towards a allied healthcare model using advanced practice providers, particularly here in the United States. There simply weren't enough anesthesiologists, even physicians, much less, available or interested in doing this preoperative, perioperative of medicine. So, I've written a book. It's in the 3rd edition. I've, trained a lot of people. We've developed a lot of protocols at Northwestern. The majority of our care in our clinic is delivered by APPs. But I don't think you can just, have it sort of just happen magically. I think when I first got into this space, nurses, RNs, delivered most of the preoperative care. I'm not sure how much of that wasn't just checklists, like a set of routine tests that were ordered by surgeons. And so I think it was a lot of sort of time, money, effort given that didn't necessarily result in any meaningful outcome differences. And I think that actually set us back quite a bit in this space of why it didn't seem to matter much. And patients would still, enter the OR with lots of inoptimized conditions. So, I've seen, particularly over the last decade, I would say, and much of it, kudos to people working outside the United States. I would say a lot of the good sort of data research and stuff, with the exception of Angela, of course, is coming from Canada, from the UK, from Europe, from Australia, New Zealand, and helping inform where we should be focusing, whether that's on nutritional evaluation optimization, prehabilitation, cognitive evaluations and optimization and frailty assessments. And in my particular, interest has been in anemia, particularly, and now, frailty, and particularly looking at the depression. And, whether that depression is present in patients preoperatively or whether they develop that during that perioperative. A lot of our patients are struggling with these chronic conditions and pain. And I think that if they're depressed and they're not motivated to, be a partner in their rehabilitation, in their care, it really limits us. I think Angela particularly has done so much good work in this, of bringing the patient into this conversation, bringing the patient in as a partner in what we decide and how we decide to do things, and then how that all transpires.
Thank you so much, BobbieJean, for all the work you've done. I know we already have a question, people wanting to know the title of your book.
Well, so Angela was a contributor. Dr. Vetter here on this call was a contributor. And I would say, it is a multidisciplinary. We have a lot of surgeons, anesthesiologists, internists contributing, and it's perioperative evaluation and management. And it's available on Amazon, not to be commercially, but it's a relatively, I think, a cheap book or a very affordable book. I
lots of value.
Well, thank you. That's what I was saying. I hope that it helps people take care of more people.
Well, our next panelist is Professor Tom Vetter. He's the Director of Perioperative Care and the Director of Comprehensive Pain Management, Professor of Surgery and Perioperative Care, and Professor of Population Health, which is a huge topic we're discussing here at the Dell Medical School at the University of Texas in Austin. And he's also the Deputy Editor-in-Chief of Anesthesia and Analgesia.
I'm in Austin, Texas. Austin, Texas is probably, perhaps with the exception of Boston, well, maybe Chicago, I don't know, but Austin is an incredibly complex healthcare ecosystem. And what I mean by that is it's an interesting place to stand up a brand new medical school. Dell Medical School was created about 5 years ago. And I think the most important message I can convey is that our perioperative surgical home and our perioperative medicine program is actually not based at Dell Medical School. I'm the Dell Med guy in the community, as I'm referred to. So we have a very hybrid model that's based at Ascension, Texas, or Ascension Seton, which, as many of you know, is a corporate entity, nonprofit based in St. Louis. And so our perioperative medicine clinics are fully embedded within a community-based setting, which is a very interesting model. Many of us on this panel, I would take inventory, are probably in academics, which is where I was at the University of Alabama at Birmingham for the better part of a decade, where I cut my teeth in the perioperative medicine space. But here what we have is me as the representative from Dell Medical School as the academician, but that's a very relatively small overall contribution. We have a very large private practice anesthesia group that's been in existence since the mid-1970s, Capital Anesthesiology Association, which is now owned by U.S. Anesthesia Partners. We have Ascension, Texas, which is a very large entity across the Central Texas market. We also have one and now two primary care practices who contribute internal medicine hospitalists to our clinic. So we have internal medicine hospitalists who are jointly staffing all of our clinics, which is a model that I had idealized in my mind when I was at UAB, but it never came to fruition. And so we have this kind of rich, complex kind of coalition government, for lack of better words. And for me, it's awesome to have internal medicine hospitalists, to speak to BobbieJean's background. You know, anesthesiologists oftentimes don't know what they don't know. And I'm a card-carrying member of the American Society of Anesthesiologists and am proudly an anesthesiologist. But when you move into the perioperative medicine space or specialty, you have to be very aware that there's a lot of content expertise in the internal medicine community. And in my world, we have to be very careful that we don't disenfranchise or alienate our primary care, particularly our general internist and family practitioners, who are the primary source of referrals for our surgeons. And that's a very unique model as well. At UAB, there was far less concern about that. The surgeons were kind of a captive market, for lack of better words. Whereas here, we have to make sure that the primary care physicians don't view our perioperative medicine presence as a threat to their livelihood, because many of them are accustomed to providing perioperative assessment of a patient and, you know, the so-called clearance with the somewhat infamous prescription pad note that says patient cleared for surgery, which we all know, we chuckle, we smile, but that still represents some potential book of business for primary care practices. So you have to tread kind of lightly if you're going to move into that space. So it's been a very interesting 4 years. As of September 1st, I've been here for 4 years and I've thoroughly enjoyed it. But this is a very unique environment, which has applicability perhaps to other settings that are not academic, for lack of better words.
Yeah, absolutely. I'm from Kentucky, and so we have a lot of challenges in private practice as well here, and academics for that matter. Dr. Rob Shakar, he is the medical director of a 32-physician group in Wilmington, North Carolina. And I know you oversee the perioperative surgical home project for the new Hanover Regional Medical Center there. And you also serve on the chair of the Perioperative Surgical Home Steering Committee for the ASA. Rob, thank you so much for being patient. All of you guys, thank you.
I think we're very fortunate. We are in a large community-based hospital, has over 800 beds. We were approached by our administration about 5 years ago because they were having difficulties with readmissions on the orthopedic side. And fortunate enough for us, the ASA was starting their surgical home collaborative, which we were one of the initial members. And using that expertise, we realized that we were fragmented and really siloed in the way that we cared for these surgical patients. And as Dr. Vetter was saying, we began talking to our hospitalists who were taking care of these patients, our surgical patients afterwards, and realized, hey, if we could do something ahead of time, we may not have these issues post-surgery, and even talking to our surgeons with readmissions. And so we kind of formed a coalition with our hospitalists to create that preoperative surgical navigation center and used our risk assessment tools to determine which patients were going to bounce, which we thought were going to bounce back. Also using the other, looking at frailty and mini cognitive. When we got everybody in the room talking about it and standardizing the approach from the time of surgery to 30, 60, 90 days post-discharge, in that first year, we were able to save about $4 million just on that one service line. And so got the attention of our administration, and now we have done it. We've rolled it out to 15 service lines within our hospital system. Been very successful, very fortunate, but it really, as everyone says, it requires bringing everybody into the conversation, all stakeholders, educating the patient. The patients like it because they're really involved. They hold us accountable. I need to be up and walking. I need to be doing these things. And the results are so much better. The outcomes have improved. And it's really helped our facility get ready for value-based payments, to have that standardization. And when the surgeons start to see how much better their patients are, they're actually coming to us saying, hey, I want to do this for a different service line. And it has really helped our hospital coalesce and everyone get really excited because, we're not just anymore just, hey, can I get the patient through the surgery? It's, I want to optimize them ahead of time, and I want them to be better and get out of the hospital faster and to do a lot better. And so we've been very fortunate from that perspective. We've been able to go to other facilities, teach them and learn from them as well, talking to some of these panelists as well in order to improve. It's been really exciting for our practice to be able to do these things and to be able to improve the care of the patients in our community.
Yeah, absolutely. It's so wonderful to hear the theories in motion here. You guys are all doing a great job about that. Well, Saul, back to you, buddy. What are the big themes that are sticking out to you that you'd like to comment on?
We certainly all subscribe to the importance and need for multidisciplinary approaches to this component within the healthcare continuum. I think perioperative medicine is I always think of a Venn diagram where there's truly an intersection between surgery, anesthesia, and medicine, and perhaps even a subset of medicine called geriatrics that really create this convergence of what we're now creating as a novel science, if you will. Perioperative medicine, I would say, is a new clinical science that really incorporates all of that. There was one comment I just want to sort of bounce back to, and I think maybe Tom mentioned this about the need for our sensitivities of the primary care provider to not be offended or perceive what we're trying to develop in our construct of perioperative medicine to be competitive. And I think it's real. I think we have to have sensitivities to that. And on the other hand, I must say that, and Rob, you and I had this conversation, I think about a month ago, that I don't think we should approach this with an arrogance as if to say we can do something that they cannot, because I think that's simply not true. They can do this. But that said, what I've learned in my experience, and I'd be curious what your experiences are, Bobbie, Tom, Angela, is that though they can do this, they can't do this. And what I mean by that is that the way that primary care medicine is designed today is sort of tethered to this productive pressure where they're typically seeing 20, 30 patients a day in their clinic. They're slotted for 30, maybe 40-minute slots. Half of that is taken up by medicine reconciliation, and it's a real churn and burn factory. And so for us to expect that the primary care providers can truly be perioperative physicians that will attend to the focused needs of getting a patient ready for surgery as it would really pertain to our focus of what that means, I think is not necessarily true. So I accept that they can do this. There's no competency hierarchy here where we have skills that they don't, but they can't do it because the system is just not designed to enable them to do that. Thoughts?
Well, I think I agree with you, Saul. I think it's an issue of bandwidth more than anything else. And they do have very high expectations of productivity. They also have a much more protracted timeline. When I've worked with a couple of our internal medicine hospitalist team members, I remember specifically working on a hypertension protocol. A patient presents with marginally controlled hypertension that needs to be tuned up. And the internist's perspective, even though he's a hospitalist and he takes care of acutely ill patients, was, we'll see the patient back in 4 to 6 weeks to see if this adjustment to their blood pressure medication was effective. And I was like, no, we got to dial that back. So he goes, okay, how about 4 weeks? And I said, no, that's not going to work either. So we finally compromised on 7 to 10 days, but I had to allow him to come to that. I think the one quick observation I'll make is whenever we make an adjustment to a patient's existing medication regimen, we make sure that we communicate that day to that patient's primary care physician, because the person that they're going to call, the patient will call if they have any concerns, is their PCP, either because they're not completely confident yet about our decision making, or they just want a sounding board, or if they have side effects, they're likely going to call their primary care physician. And out of professional courtesy, if nothing else, I think it's vitally important to let them know, hey, I increased your patient's metoprolol dose. So if you get a call because they're having some symptoms, I want you to know, because that's another set of eyes and ears to potentially put on the patient. So I think it's just professional courtesy, but I agree with you, Saul. It's not an issue of core competence, and it shouldn't be transactional. That's what unfortunately happens in medicine, as you know, only too often, is that in order for us to win, someone else has to lose. That's unfortunate, and that's, one of the questions was, where are we at with perioperative care? I think it still is viewed as a potential transactional opportunity, which I wish and hope we can get beyond that.
No, I actually disagree a little bit, and maybe it's because of my particular interest in shared decision making. Is in my experience, I completely agree that they have the same core competencies in terms of long-term management of blood pressure, anemia, all of that. Where I think we provide particular value in the perioperative medicine world is risk assessment. Because I don't think we can all gather the information. I think what we have the competency to do is put all the pieces together and truly discuss risk benefit, because I don't think primary care doctors understand what happens in the operating room and the effects of anesthesia. So that's what I think that's what we bring that cannot be done by a primary care doctor.
I accept that, and I think that's profoundly wise, and I will modify. Hereafter, I will modify my position to reflect that, because I think you're right on.
Thank you so much. Okay.
Yeah. Well, BobbieJean, I would add. Rob, go ahead. Go ahead. No, go ahead.
Real quick. I think that as healthcare is changing towards value-based, and we're trying to align with our primary care partners and providers, I think we have to be able to make that segue to population health metrics, because I think that they're it's focused on that from an ACO perspective and covered lives. And it is kind of the hospitalization and the surgery, which are very expensive procedures, or things that they really don't have that control. So I think working with them in the preoperative aspects and avenues help them to understand what we need, but it also shows them that we're also trying to be good partners for them in the future and be aligned with them and what their goals are as they work with ACOs and cover lives of their patients.
Yeah, I think it's complementary, not competitive. We bring something and they bring. That's the way I look at it.
As someone who worked in primary care and internal medicine, and now, is more in the hospital-based perioperative world, and as someone who went from a very academic place to when I first entered in Northwestern, it was, the clinic was run by hospitalists, and it was a very private practice kind of model where the surgeons were very dependent on the internists and patients and everything. And there was very great concern that I would come in there and disrupt the apple cart, and that there would be a lot of discord, in terms of being unhappy. And I would say the absolute opposite has happened. And the way I look at perioperative medicine is its specialty. It's especially just like cardiology is, just like endocrinology is. And primary care doctors and PCPs routinely refer to their patients. In fact, more so than ever. When I practiced primary care, we took more care of patients. We actually managed them. Now, I think primary care doctors are very much into outpatient medicine, right? They never come into the hospital and see their patients. They don't manage acute care patients. They don't see their patients postoperatively until they're discharged from the hospital. And primary care doctors are focused on really much more preventive care, much more management of risks in a different way. Risks for how long you're going to live, or how well you will be 10 years from now or 20 years from now. It's not in what's happening right now. So what we did was we tried to just partner with our primary care doctors and make sure that we kept them in the loop, make sure we engage them. But increasingly, the primary care doctors are grateful and happy that they don't have to worry about keeping up with the bridging guidelines that are necessary for a patient who's anticoagulated, who's going to have surgery, because they don't know about regional anesthesia and what, Angela mentioned and about, the impacts in this acute care. They often, the patients are now not necessarily being referred from their primary care doctors to their surgeons. They're actually finding their surgeons on their own, because they either had their first knee done by their surgeons, or they're having their second knee and their first hip and their third, or they're going to somebody because their wife or a family member or somebody. So the first time the primary care doctors often know the patient's having surgery is when we call them, not when the surgeons call them or when the patient calls them, but when we call them. And they do appreciate that we include them as partners in this, that we know we're going to hand them back off to them and they're going to take care of them, that they don't get surprised. And as I believe Angela mentioned, that, the first people they're going to call are going to be their primary care doctors about something. So we do think it's a partnership. But frankly, I do not think that they have the knowledge or the skill set to do perioperative medicine. That's not degrading them in any way, but it's saying that medicine has gotten so complicated, so specialized, so super, focused, that we are just like a cardiologist, I believe. That, the primary care doctors still follow the patients, but they may see their cardiologist for a consultation. They may see them once a year in concert, and they have to work together. And so I think that we need to, if we're going to be in this space, the hospital in this space, or whoever, they need to really specialize in this space, because you can't spread yourself so thin. And I think primary care doctors are they can't know everything about everybody. And especially at the last minute, they may not be able to work their patients in. We get so many calls from primary care doctors in the Northwestern system who say, my patient's going to have surgery in a couple of weeks and we just can't see them. And we just don't know what you guys want us to do for them. Please see them and just let us know what you do. And then we'll pick it up on when they come home. It works really well. That model is collaborative. We appreciate their work and their help and their chronic care of the patient, but we don't expect them to do preoperative medicine.
So I do want to get to these Slido questions. So the first one here it's a great one. Our main goal is the pre-op period. So a lot of the times we talk about, pre-op optimization. However, usually we don't measure the long-term outcomes greater than 30 days. What's your opinion on patient-reported outcomes related to quality of life? Angela, I'm going to start with you on this one.
Oh, I love that question. That's a great question. So this is one of the things that we are pushing to develop. And what I really think, and in fact, I hope to engage all the other members on the panel at some point, is to develop a database that is focused on these longer term outcomes. So, for example, if the audience is familiar with NSQIP, which is this particular surgical database that we use, it doesn't capture these kinds of outcomes. So what we're trying to do, and in fact, that's some of our efforts in terms of working with companies that could potentially build it, is how could we first of all, what are the right metrics? And how are you going to get them? And that's going to require patient engagement virtually post 30 days. And then where is that data going to live? So I completely agree with the audience member that asked this. And that's something, actually, I'm trying to work on that with Matt McAvoy from Vanderbilt right now. And literally, we're just trying to push to get this started. So maybe next year at Top Med Talk, we'll be able to talk more about it. But I want to say that's a project we're actively working on, because that audience member is very wise. We don't have the right database.
Yeah. Well, Rob, from your perspective, what are you guys looking at this? I mean, the perioperative surgical home, again, the continuum of care, how is that playing into what you guys are looking at?
Well, we're very fortunate. We have a great team, someone that you've met as well as our nurse navigator, who does a phenomenal job. And I think that's what patients like, is the fact that they have that contact, that one point of contact. And our nurse navigator follows up with each of our patients after discharge to make sure they have that point of contact. She's been able to prevent readmissions. She's been able to prevent a lot of issues because she's had that one focus of that contact. And it's really helped our surgeons because they have had less phone calls, and their patients feel like they're getting a really concierge type of service. And so, yes, we are very patient focused and centered, and are following that, and are keeping our own database basically on how our patients are doing. Right. But I think it's that point of contact that patients really enjoy and like.
Yeah. So I wanted to just give a shout out to, I was going to give a shout out to Rob, because you and I had a telephone conversation, I think about 6 months ago with your team. Because when I contacted the ASA Learning Collaborative about what organizations in the United States are doing post-discharge transitional care management. Because as an initiative where we've fallen a little short, because that was one of the questions you had asked, what's the future? I think it's focusing on that post-operative phase. And I think, Angela focusing on preoperative frailty, delirium, cognitive dysfunction in the older and aging, the silver tsunami that's occurring within the United States, which Saul touched on a little bit in terms of the aging population and the increased spend that's going to occur, is the big lift is post-discharge risk mitigation and transitional care management. Because surgeons, again, are very busy, and you can do that service as the folks are doing in Eastern, New Bern, independent of the global anesthesia fee and independent of the global surgical fee. It's completely valid, completely compliant. So I think we've done a pretty mediocre job of looking at sustained 30, 60, 90-day post-operative outcomes. Yeah. To Angela's point, we're so fixated on length of stay and same-day cancellations, and to Angela's insights, some patients need to be canceled. They really shouldn't even have the surgical procedure. I mean, every week I'm in clinic, I have to have that tough conversation, right, Angela? Or BobbieJean or Rob or Saul, you really shouldn't have this surgical procedure, because do you know what your outcome likely going to be? You're going to end up in the ICU and on a ventilator. Really? Nobody told me that I was going to be in the ICU on a ventilator.
Right.
I think I want to hit the pause button a little bit on this. So those are pretty coarse when I say coarse, I mean not granular, post-operative outcomes that we're not really effectively assessing.
Exactly.
So
my hope really, I'm sorry, Tom, sorry.
No, good. I'm done. Go ahead.
I was just saying, I'm kind of trying to think big on this. I think what Rob is doing is fabulous. The problem is he's doing it as a one-off where it should be in our databases. Like what you're doing should be captured so that, and we all have the same way of entering it and we can benchmark. So this is what I'm always trying to do these big pushes here. So my goal would be to try to push toward what Rob is doing, but make it sustainable and in a database that we can access like NISQA. I don't know if I can live long enough to do that, but that's what I'm going to try to do.
Try and do. I love it.
I'm just a practical wonk, and I'm going to ask Rob, again, kudos, well done, sir. But you mentioned earlier that you were able to demonstrate a $4 million savings that I'm sure turned a lot of people's heads. How are you, from a pragmatic standpoint, doing what you're doing? At the end of the day, it's a business. Tom, sorry, but there is a transactional component to our abilities to go ahead and stand these things up. Rob, give us a roadmap.
Well, I think it's being transparent in costs and what you're doing. I think that there's, as I said, we all realized we were working in silos. There was a pre-op piece, there was an intra-op piece, there was a post-op piece, and the surgeons did their pieces, and our hospitalists did their pieces. And I think it was using the lean process, we got everybody into a room and said, look, where can you affect change to your patient, to this patient going through the process, whether it was discharge planning. So we have them talk to the patient in the preoperative realm and get them ready for surgery. We were very fortunate enough. We've been a little outside the box. We got a grant from Duke to have paramedics go to the home that we felt like there were going to be safety issues. And so we send paramedics out to the home that we think that there might have areas of steps or rugs that might slip and falls and those types of things. And so trying to be the complete entity of looking at that entire episode of care from post to discharge. And I think having everybody in a room saying, hey, these have been my issues, how can we address them, really helps. But I think it's really in transparency. Of course, the savings comes from the surgeons decreasing the number of implants and having better costs for that. A lot of surgeons didn't know what their preference cards, what the things cost on theirs. We had surgeons using a $50 saw and some using a $500 saw. And when you got them into the room and they were motivated, they realized, hey, we have areas that we can really save money and decrease our costs. In fact, we were very fortunate last year. We were identified as having the facility in North Carolina that did joint replacements at the lowest cost in the entire state. And so, it's that kind of positive reinforcement and the results of and really it's focused on the patients more. They're very happy. They're really excited about having their surgeries and knowing that we're doing evidence-based protocols for multimodal pain management, for getting them up and moving them around. And the surgeons really speak highly of it. And so I think it's that collegial and transparent a way that we are now taking care of the patient and putting them as the focus of what we're doing. So.
Saul, I just wanted to clarify, when I said transactional, I recognize, remember, it was a Catholic nun that came up with no margin, no mission, and I work in a Catholic faith-based system. So I can assure you, no outcome, no income. And we had to go through 2 pro formas, and our P&L is reviewed quarterly. What I meant by transactional is if we make it seem like in order for us to win, another group has to lose. That's the transactional part that is going to be very counterproductive. But to BobbieJean's point, perioperative medicine is a legitimate specialty as witnessed by this conference, just like if this were an international cardiology conference or an international endocrinology conference. So we just need to take that high ground. But believe me, if I weren't operating in the black, I wouldn't have a program at Ascension Seton, or they wouldn't have a program.
Understood, and certainly very familiar to all of us. Very quickly, I know we're running out of time.
Yeah, got to wrap up, so.
Rob, I think what you just described is a very nice illustration of true practice of episodic care being total cost of care throughout the episode, and that we all have to integrate the shared savings, shared costs versus cost shifting, which is to say, tag, you're it, my gain equals your loss, if you will, in that zero-sum game. The idea that you can't afford a nurse navigator to do post-operative transactional care management is predicated on somebody changing their card for a saw that is less expensive. And when you lump that all together in a collaborative total cost of care model, then you get the opportunity to see where you can get those savings. And I think it's a really important point, and it's a really difficult culture to change too.
Oh, yeah.
One in 30 seconds or less, future of these perioperative care bundles. What is the biggest opportunity? I know, Tom, I'll go to you first because you mentioned it very quickly earlier.
I think prehabilitation. I think psychosocial cardiopulmonary are going to be vitally important. Cardiopulmonary, psychosocial, and nutritional prehabilitation. It's an untapped opportunity and one that we want to pursue pretty aggressively.
Love it. BobbieJean.
I've always said having surgery is like running a marathon. We need to get these patients motivated, trained up, and we need to have them realize that they have a big input in their outcomes. So they need to be motivated. We need to treat their depression, treat their chronic conditions, but really educate them on what to expect and what they need to do to improve and recover after this major surgery.
Yeah, great. And Rob?
I agree with BobbieJean. I think you have to make the patient the center of what's going on. They have to participate in their care. They have to know what the expectations are, and they actually have to hold us accountable. And I think we can put together the evidence-based risk assessment tools to address and optimize them for the surgery, but really making them the center of the care is the most important aspect of it, and will help you be the most successful.
Yeah. Absolutely. Thank you.
I think patient engagement is the hugest untapped opportunity. The problem is we don't have good ways of doing it. It's the biggest opportunity, and I think right now one of the biggest challenges.
Well, I'm glad we've had this conversation. Hopefully it'll contribute to that because all you guys have such wonderful experience. And Saul, we'll end with you, buddy. What do you think? What is it? Biggest untapped opportunity?
Between data or evidence and change is reality. And I think reality is a culture, it's emotion, it's trust, and it's making it easy to do. And I think what we all agree on is that perioperative medicine is the newest clinical science, and it has its own unique opportunities and challenges.
Amen. Well, thank you so much for listening wherever you are in the world. You can be sure to check out the bios of our panelists on ebpom.org, and I'm sure all of them would love it if you you could contact them and talk to them about their stuff.
I love it.
Everybody loves to share their experiences. Yeah. So panelists, Tom, BobbieJean, Rob, Angela, Saul, thank you so much for the time you contributed to the EBPOM Chicago meeting. Cheers, everyone. We'll see you on the Chicago stage at 10:30 Central Time. Go
Stay
Cubs,
safe.
go
Be well.
Love you all. Stay safe.
Bye, guys. Love you. Bye.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.